Good morning, colleagues. COVID-19 conversations are brought to you by the African Alliance with support from the South African Medical Research Council and the Department of Science and Innovation, and the Vaccine Advocacy Resource Group, which is 100% funded by activists. We bring you these calls in partnership with the Community Constituency COVID-19 Front, the Treatment Action Campaign, and APHA. Thank you for joining us. These calls occur every Thursday at 10 a.m. and seek to bridge the divide between civil society and those who hold power and platform in the COVID-19 space. All of our recordings, along with the transcript and the Q&A sessions, can be found at africanalliance.org.za. We encourage pre-submitted questions and welcome questions or comments in the chat box during the call, and we will do our best to answer all of them. Those we do not get to, we will reach out to our guest after the call to secure those answers, and those will be included in the transcript. Today, we speak with Rosemary Mburu about global health in the age of COVID-19. Mburu is a founding member of the Vaccine Advocacy Resource Group, has been a champion for healthy communities for over 15 years, and currently serves as the Executive Director for WACI Health. Mburu is a civil society leader in Africa and has extensively supported civil society to engage with decision makers at the community, national, regional, and global levels. As a civil society leader, her contribution includes facilitating spaces and networks that enable Africa's leadership in global health. These include the Civil Society Platform on Health in Africa, the Global Fund Advocates Network Africa Hub, Africa Free of New HIV Infections AFNI, and the Civil Society Engagement Mechanism for UHC 2030. Ms. Mburu's work focuses on creating political will and ensuring accountability towards improved health outcomes for all in Africa by engaging with governments and key multilateral and bilateral global health institutions. Mburu has served in various capacities within the global health architecture, including on the UHC 2030 Steering Committee, the UNITAID Communities Advisory Group, and the Gavi CSO Steering Committee. She is a member of the African Union Commission Technical Working Group on Investing in Health. Ms. Mburu has co-authored several peer-reviewed journal articles and holds a master's in public health from Ohio University, a master's in business administration from Frostburg State University in Maryland, and a Bachelor of Education degree from Kenyatta University in Kenya. Rosemary Mburu, thank you so much for joining us. It's always a pleasure to speak to you. Welcome to COVID-19 Conversations. And without further ado, we will hand over to you to introduce us to your work as the head of WACI Health.
Thank you so much, Tian and colleagues. It's a pleasure to be here. And congratulations for putting these conversations together. It is a critical time, not only for the world in terms of responding to COVID-19, but also very importantly for civil society and communities to engage, to ensure that we are keeping updated in terms of the information that is rapidly evolving, and also particularly as far as the COVID-19 tools are concerned. So as I have been introduced, I work for WACI Health, which is an Africa regional advocacy organization. For the last 23 years, our work has mainly been anchored on convening and supporting civil society and community voices to engage on health response across Africa, to engage with different global health institutions. I also did want to mention that in our strategy around convening civil society and finding a coordinated Africa civil society action and voice across Africa, we have done this, or we do this through a number of platforms, or the way we organize has emerged into a number of platforms. So one is the Africa Free of New HIV Infections, which is a network of African advocates who work around ensuring an Africa free of new HIV infections, whether it's in terms of policies, ensuring that we have policies that contribute to ending new infections within HIV. We also, if we could go back to the first slide, please, just the first one. Yeah, there's also the Global Fund Advocates Network Africa, which is GFAN Africa, which mainly works around the world, but specifically GFAN Africa is the Africa hub for the Global Fund Advocates Network. And within this particular platform, we are very much interested in resource mobilization for the Global Fund, but also around accountability on how resources are utilized at the country level. There's also the African Civil Society Platform for Health, which mainly engages with the African Union Commission and other regional economic blocs like the EAC, ECOWAS, making sure that the civil society voice is at the table, and not just being at the table, but that there is meaningful engagement and contribution. There is also the Civil Society Engagement Mechanism for UHC 2030, which is a global civil society platform, which WACI Health co-hosts with MSH and brings together colleagues around supporting as well as accountability for universal health coverage, mainly looking at health systems strengthening for universal health coverage. And the last 3 logos down there, actually, they are logos for a platform that was recently launched in April. This is Top 8, which is an organization based in the UK, and also the Global Fund Advocates Network Global Secretariat. Together, we've come to support convening of civil society and community reps who sit on the ACT-A. Later on, I will share a little more about what the ACT-A is. It is the Access to COVID-19 Tools Accelerator. And within that structure, there are 4 pillars, and we'll look at a slide that specifically explains that. And within those 4 pillars, which is diagnostics, therapeutics, vaccines, or what we also call COVAX, as well as health systems strengthening. And within those 4 pillars, you have civil society and community reps. And so the platform for civil society and community reps that is led by StorePage, WACI Health, and GFAN is working towards ensuring that we have a robust civil society and community constituency within the ACT-A. Next slide. So when COVID-19 hit, there are many ways through which different organizations responded. Our first reaction was to say, how do we ensure that as countries are rapidly responding to COVID-19, they are also conscious that we cannot forget the other responses that we had. In Africa especially, COVID-19, the fight on COVID-19 came on top of what Africa was already battling with. So we already had responses on HIV, on TB, on malaria, and many other responses that as a continent we've been battling with, we've been responding to. And so COVID-19 came to find our health systems in a condition of being fragile, because already we've been struggling with other conditions. And so I think the biggest voice from WACI Health at that point was to say, yes, we need to respond to COVID-19, but we must ensure that we do not reverse the gains we have made on HIV, on TB, on malaria, on maternal health, etc., etc. And 3 key messages stood out for us. And one was around additional resources. So basically we were saying that for us to defeat COVID-19 and safeguard the critical fight against HIV, TB, and malaria, and also other elements, like maternal health, additional domestic and international funding is needed. And so we were really looking at ensuring that additional resources was being mobilized here at home, but also at international level in terms of responding to the existing global health responses. And the other message was around ensuring that issues of gender barriers, stigma and discrimination, human rights were not forgotten, because COVID-19 response was evolving so rapidly. There were clinical trials going on, there were rearrangements within the health system, there were lockdowns and many other new things that we had not seen before. And this message was about to say, yes, we are in a haste to respond to this pandemic, but even within that, we must not forget that we cannot win and we cannot respond, or no global health response can be successful if we are not paying attention to gender barriers, to stigma and discrimination, to human rights barriers, and those had to be integrated within the response. And the third top line message was around global solidarity. So to defeat COVID-19 and make progress against HIV, TB, and malaria and save lives, we must unite to fight. So this was a message about solidarity, and actually inspired by the fact that we had already started seeing the nationalization of resources, of just the thinking, and countries just wanting to think about the people that sits within their borders, and really forgetting that when it comes to global health, especially global health security, we are only as strong as the weakest health system in the world. And so that was a message around solidarity. Next slide. Yeah, so also very important, when COVID just happened, one of the areas that really suffered was on sexual reproductive health and health rights, especially for young people, because already we know that young people have issues in terms of access to sexual reproductive health and rights, whether it's services, commodities, facilities, etc., etc. And so with the COVID-19, the lockdown and the situation that happened, this situation actually was worse because you had organizations that have been supporting young people to access services closing down. You had facilities where young people, maybe youth-friendly facilities, closing down and maybe becoming COVID-19 centers, etc., etc. And so we did a series of conversations under APHA with young people, having weekly conversations to see what were they struggling with, what were the biggest needs, and that conversation led into a policy brief, which then we shared with policymakers. And we partnered with different youth networks, including Her Voice, Youth for UHC, Ready for UHC, and the Global Network of Young People Living with HIV. So that was another area of work that emerged as very critical and important to ensure that young people were not struggling so much because of the situation, the lockdowns, the lack of access to services, and inadequate facilities. And this is also, just be cognizant that in most of our countries in the region, very few countries actually have youth-friendly facilities that have youth-friendly access, to services. And that really makes it very difficult for young people, especially where sexual and reproductive health and rights is surrounded by stigma for young people. Next slide, please. So this is perhaps the slide I take a bit of time on, because I had mentioned in one of the slides that WACI Health is partnering with Stop AIDS and GFAN to lead on a platform. It's a global platform that helps to convene and support civil society and community representatives on the ACT-A, the Access to COVID-19 Tools Accelerator. And so I thought it's important that we also take a bit of time to understand the ACT-A, how it's functioning, and what the role of civil society is within here, because it's a very important global health mechanism, I would say, within COVID-19 response. And there is a lot that is happening in there. So the ACT-A was launched in April 2020 by the WHO, European Commission, France, and the Bill and Melinda Gates Foundation in response to a call from G20 leaders in March 2020. So the call by the G20 leaders was in March 2020, and the accelerator was launched in 2020. It is a collaboration to accelerate development, production, and equitable access to COVID-19 tests, treatments, and vaccines. And this is basically the structure of ACT-A. So you can see the vaccines pillar right here, and well, maybe you can't see me pointing, but you can see the vaccines pillar there, which is led by Gavi, as well as the Coalition for epidemic preparedness, CEPI, and that's what normally you'll hear people calling COVAX. It's the vaccine pillar. Then you have therapeutics, which is led by these two agencies, UNITAID and Wellcome Trust. Then you have Health Systems Connector, which is led by the World Bank and the Global Fund. And you also have Diagnostics Pillar, which is led by the Global Fund and FIND. Then you have a cross-cutting working group, which is called Access and Allocation. And within that, these agencies that are leading the different pillars are working with governments, with civil society, as well as industry, private sector. So for civil society, there has been a transparent process inviting applications to sit on the different pillars. So you have civil society sitting on the COVAX, you have civil society sitting on the therapeutics, Health Systems Connector, the call is out right now. And there's also representatives within the diagnostics pillar. And so one of the things that I guess we can say we are learning or we are bringing to act from our experience, either with the Global Fund or with TB or with the different global health institutions, is that we really need to ensure that we, as civil society and communities, we navigate this space. It can be complex. And even though our voices are at the table as civil society, there's no illusion that our voices are equal with those of the government and with the industry. And so we have to really be organized and engage and understand what are the priorities, what are the issues, how do we engage and constantly challenge these mechanisms, constantly communicate our views, our priorities in holding the lead agencies accountable. I think this should be my last slide because I just want to then just go into a very quick highlights in terms of, having said all that, what are some of the lessons or the take-home messages given WACI Health's engagement within this? Number one is that how global health is funded is something that we need to think very critically about. One of the things we know for sure is that with COVID-19, there came an economic contraction. And for 2020 alone, Africa's economic contraction was about 2%, if not slightly more. And what that means is that as a continent, our governments are responding to COVID-19 with borrowed money. And what that means is that then our debt burden is increasing by the day. When you think about the debt we already have, even before COVID-19, then you find that we are in a very tricky and challenging situation of when you think about debt management and repayment of what we are accumulating as nations in the region. And so that's something to think about. How do we fund global health so that there is sustainability, so that there is predictability of funding? Is it perhaps time that we rethink about how aid is done? Is it time to think about how global public investments are done? Is it possible to even shift the language, from donor and recipients, and think about that aid could go either way? Like we could have African countries supporting each other financially. And is that narrative? Is it time for that narrative? So I think the point there is that we need to think about how we fund global health so that it's sustainable, so that it's predictable, and so that we do not sink further into debts, and because we will struggle with that. And what will happen is that the more we get into debts as a region or countries in this region, the more we will suffer from conditionalities. So the IMF recently was in Kenya and saying, no, you can't employ additional human resources for health because apparently there are those conditionalities and your inflation has to be less than a 2-digit something. So there's all that. So that's one. The other thing is about this whole concept around global health security. When COVID-19 happened, for me, the statement that stays with me is I kept hearing, people saying, our global health security is only as strong as the world's weakest health system, which is very true, In Kenya, for example, we cannot pride ourselves in being out of the woods as far as COVID-19 is concerned. If, for example, we are accessing the vaccines, if our neighbor in Tanzania or Burundi has no capacity to conduct a single test, etc., etc. And for me, this is what I get when I think about global health security across the borders, how diseases travel across the borders, how they do not respect levels of income. But I think one of the points that we miss, or the global health ecosystem misses, is that you cannot achieve global health security without global health solidarity. And this is what now we are seeing with the nationalization of vaccines, for example, of investments, of resources, etc., etc. So we have to think about global health solidarity. The other thing that we've learned is that no global health response will be successful without communities. We do know that when COVID-19 hit, the process was very facility-based. People would be identified and be quarantined in hospitals. And with time, hospitals couldn't actually absorb and sustain and manage the levels of the volumes of people that came. And what happened? A lot of countries had to deploy additional community health workers to actually support with that. So that's one level, ensuring that we are investing in community health workers, ensuring that there's an understanding of the role of health systems and the role of community systems within the whole response. But beyond community health workers, there is also communities in terms of who are we most likely to leave behind. So these are people who have the least access to health services. These are people who are criminalized by the laws of the same country that should protect them. These are communities actually who are very far from health facilities. So we have to learn that global health interventions cannot succeed without communities, and we have to think about which communities are we talking about? Where are they? And I think the best way is to think about who are we leaving behind? In this whole response, who is likely to be left behind? Who is likely to miss out on the vaccine? Who is likely to miss out on the diagnostics, etc., etc. So these are quick reflections on some of the things that we are learning. And the last thing is, we need to think about how do we move from emergency response to preparedness. We have to be better prepared. It can be challenging because then you have to balance between having money tucked somewhere for when an emergency happens, while actually the women in your country are dying while giving birth. So your maternal health response is weak. So there's something to balance there. But I think at the end of the day, we have to think about how we finance and how we prepare for emergency response. For COVID-19, personally, I'm very proud of how the African CDC has really provided leadership. It has been a lighthouse globally for how you actually lead a response in a region. And so are there ways through which African CDC response can be supported, infrastructure strengthened? Just thinking about how do we ensure that beyond COVID-19, we continue to build our regional leadership, our regional capacity to actually respond. So Tian, those are just quick reflections from what I've been seeing in the global health space as far as COVID-19 is concerned. And I'm happy to engage in a conversation or reflections from other colleagues. Thank you.
Great. Thanks so much, Rosemary. I think it was a really deep and broad perspective of the work that WACI Health has been doing since the advent of the pandemic. But one thing that really occurred to me as you were speaking is this concept of solidarity, and how do we meaningfully build that solidarity across borders, whether you're looking at a country like South Africa that is deeply Afrophobic, at the best of times, not even, within a pandemic. And there's this very strong current of Afrophobia in terms of service delivery, in terms of housing, let alone accessing a COVID vaccine. So what are your thoughts on how we practically build this solidarity in the context of a pandemic, highlighting what you said of the virus does know no borders. And even though we in South Africa might attempt at times to pat ourselves on the back and say, we're leading the region in terms of rollout and programming. We saw Ghana got their first delivery yesterday, with Cote d'Ivoire coming on board in a few days' time. But so amongst all of this fast-moving landscape, how do we practically build solidarity when there's such competition for resources and positioning between countries? We saw South Africa come under huge attack for the procurement of the AstraZeneca vaccine that is now being sold to the AU, et cetera, et cetera. So how do we navigate, in your view, these very complex regional political, geopolitical dynamics to really build that true sense of solidarity?
Yeah, three things come to my mind, Tian. One is that we have to learn. Our countries have to learn. We as individuals have to learn. And I think for me, the best place to learn from is what happened in Italy. It's still vivid on my mind when the Prime Minister of Italy stood and said, you know what, beyond here, I do not know what to do. It is beyond me as the leader of this country. It's beyond us as a nation. We just now need a supernatural power to help us. What the power in that message is saying that as a nation, there comes a time when you cannot save yourself. There comes a time when your wealth cannot save you. There comes a time when your privilege cannot save you. And for me, that's a huge learning to say that we need each other within the country. And when a pandemic like this hits, it actually reduces us to just the same, to one people. Like we struggle together, we go through hell together. And so for me, that's a reflection to say, what can we learn? That a nation is so affected to a point where the leader, just surrenders and acknowledges that not our wealth, not our privilege, nothing at this particular time. We just have to stick together as a nation. And I think there are lessons there for even our governments that perpetuate discrimination within the same country, that leave other people behind, where not everybody is treated equal. There is a lesson there for our countries and also for the globe. I think the other thing we need to do is that we really need to push for strengthening of our regional bodies. I like to think that in the absence of the African CDC, I don't want to think what would have happened in Africa, because clearly nobody was thinking about us. We had to think about ourselves, like we needed our own leadership. And that's how African CDC helped in terms of that leadership. So going forward, we really need to think about that regional solidarity, and knowing that when something like this happens, we really need to rally resources as a region. We really need to back each other. We really have each other to actually navigate through this. What we are learning from the nationalization of resources, of vaccines, et cetera, is that we need to think about models of sustainability in terms of financing, in terms of setting up infrastructure, in terms of strengthening our capacity to respond to pandemics, strengthening our capacity to roll out, diagnostics, therapeutics, and vaccines, when such a thing happens. So just thinking about what we learn from what we saw, from countries like Italy gave us a really deep lesson. What we have seen on what regional coordination means and why we need to ensure that we continue to build on that, even beyond the acute phase of responding to COVID-19. And the third thing for me is that as civil society and communities, as people in low and middle income countries, together with our governments, we need to reshape this narrative. We need to call for solidarity. We need to, what is happening with the People's Vaccine campaign is amazing because it brings together, we as the people, together with our governments and the agencies, UNAIDS, to really tell the rest of the world that we need a people's vaccine. And what this campaign is doing, it's shifting, it's changing a narrative in terms of saying, we cannot win this unless we actually have a people's vaccine. So it's about building a narrative around solidarity as a people, together with our governments, decision makers, agencies. So those are my three thoughts, Tian.
Thank you for that. Colleagues, a reminder, you can share your comments or questions in the chat box and we'll get to them. Rosemary, WACI Health has been a long time leader of really driving ahead the discussion of domestic financing for health responses. And I'd really be interested in hearing your perspectives on, do you think COVID has shifted that needle ahead or perhaps backward? But what do you think the impact of COVID has been on the advocacy work to get governments to increase their investment in domestic health financing?
Yeah, I think COVID-19 has emphasized the need for governments to invest domestic resources. And it has emphasized the need for governments to figure out how to do that. One of the things we have learned during our work is that a lot of governments actually do not have a fiscal space that can actually allow them to expand their investments, their domestic investments in health. So we need to take a step back and have conversations with governments on how they can expand their fiscal space to increase their revenue base, to diversify how they can tap into more revenue. One of the biggest avenues through which our governments can raise additional resources and expand the revenue base is by strengthening the tax systems, how tax is collected, how it's allocated, how it's generated, and how it's accounted for. Those are things that within our region, we have a lot of room for improvement for those. So we have to think about mechanisms of strengthening our tax revenue systems within our countries. And that should not be confused with taxing people more. So we are not talking about increasing the taxes or additional taxes. We are saying for the taxes that have already been agreed within a country, we need to interrogate how is the collection system, how is the allocation system, and how is it being accounted for? Because if you did only that, you could actually help to generate additional money. The second thing is that for the money, the little money that we already have, we are not being good stewards of that money at the country level. There are high levels of inefficiency within our countries. So we have to ask for additional money, yes, within the health sector to do the things that we need to do, but we also need to call for efficiencies. We need to hold agencies accountable for the money that they have. There are so many loopholes, which is why even the little we have actually is not necessarily effective as it should. So we need to talk about allocative efficiency. Where are we allocating money? And are those the areas that actually will give the impact we are looking for? Are those the areas that will give us better health outcomes? Where are we putting our money? So it's about resources in terms of additional resources, but also very much about what are we doing with the resources that we already have.
Yeah, thanks for that reflection. I think a commonality with many of our countries is that is mismanagement, maladministration, corruption. You know, in one district in South Africa, within one financial period, just one individual was convicted of looting the equivalent of nearly 100,000 Pfizer vaccine doses. And it made me think, you know, how do we go to communities, especially in countries where there are phased rollouts, and say, well, you as Mr. or Mrs. General Public will not get the vaccine for another year because we're prioritizing healthcare workers and we don't have the resources. But yet in that very same day or that very same week, they've read the headlines and they've seen how the public health coffers are being looted. So having said that, and looking at the impact of this on civil society that has traditionally been underfunded, under-resourced, and in some countries certainly clamped down and oppressed, what particular challenges have you seen in building that solidarity in a COVID space now where there is extreme competition for resources within civil society to carry out COVID work, but not only carry out COVID work, but to continue their traditional work, whether that's in GBV or agriculture reform or access to water or access to justice? What are some of your reflections after all these years at the helm of WACI Health convening groups of civil society? How do we build civil society solidarity in the current environment? And could you comment specifically on how we build solidarity where there's intense competition for resources, as there always has been? And secondly, for political space, whether it's on AU platforms, WHO platforms, United Nations platforms. So a general overview from you, if you will, on building that solidarity and dealing with those relationship dynamics within civil society.
Yeah, so in terms of solidarity, one thing to acknowledge is that we have many civil society groupings, many civil society platforms. The way civil society in country A organizes might be different from the way civil society in country B organizes. But there needs to be a point where we can all come together. And it's okay to have as many coalitions as we can, as many networks as we can. But I think we need to find a way where our thinking can meet, where our priorities can meet, where we champion the same cause. I keep giving the example of the people's vaccine, because I know I have heard about that from different civil society organizations and groupings and networks. And I like the way we are being led on a concept. We are being led on an issue. It's quite issue based. It doesn't matter what kind of an organization I'm leading. It doesn't matter whether I'm competing or my priorities are competing with those of the African Alliance. But we are united by the fact that we believe in equity. We believe in the need to ensure that everybody is vaccinated, can actually access a vaccine and other tools. So can we find a way of how we actually meet on issues, on priorities, how we can have calls or consultations, or how can we strengthen how we talk and how frequently we talk and what do we talk about. So just being focused on issues, on the cause, on the desired outcomes, I think framing it like that would help us a lot in our solidarity, and less of who is funded by who is not funded, and really stay away from even categorizing. You have international organizations on the continent, you have regional organizations, you have national organizations. At the end of the day, it's very important that we come together on the cause that actually unites us, because at the end of the day, it's for the benefit of the person. But something that comes to my mind also is that we should have our work more and more be people-centered or human-focused, as opposed to it being systems focused or really determined by the politics of the day. If you're thinking about the person, if you're thinking about the human, we will think about the best thing for the person and not for the system and not for the politics. We will think about, what does this person want? How can I use my voice to call for the things that people want? Who else is within that ecosystem that I can work with? And that will really help us to work together. And then there's also the angle around access to resources for civil society. And I know it's a very big topic. One of the things we could do is to be more vocal about how civil society advocacy work is funded. You find that a lot of funding agencies will not fund African civil society directly. So the funding will come from a foundation in the US, and it has to first go to an organization in the US before it can come to an NGO or a civil society organization in Kenya. And within that whole trail, you have a lot of admin and overhead money, that stays there, that perhaps we could leverage for actual advocacy work. So that's how is advocacy work funded? So that's something to think about. But also, we need to think about, when advocacy organizations are funded, what exactly is funded? One of the challenges is that advocacy work is funded, is activity based in terms of the funding. So you have partners who want to fund activities. And what we are seeing during COVID-19 is a lot of organizations, a lot of advocacy organizations going down because there are no activities that are funded at the moment. It is true that we have a lot of colleagues and organizations that do this work on voluntary basis. But it is also true that for organizations to survive, you need to invest in the structures. You need to invest, in the institution for you to actually have a sustainable work and voice. So it's how organizations are funded. I think that's something to think about, and what is funded within organizations. And I think that can really help with this any tension around who is funded, who is not funded, etc., etc. But it's a bigger topic that perhaps we should have a conversation about.
Absolutely. I mean, some of the work that the Alliance does specifically also focuses on this concept of decolonizing the global development health space and what that means, especially in terms of the flow of money. But having said that, I want to now bring us a bit closer to home in terms of preserving the legacy and preserving the investments, political, infrastructure, human, that we have made in the areas of TB, HIV, malaria. So a two-part question. What examples have you seen of preserving those gains and not losing them based on the drop-off numbers we've been seeing? Certainly in South Africa, in one province at the outset of the pandemic, we lost 600,000 people in terms of chronic medication. These are people who stopped going to the clinics. And they had to develop a public-private partnership with Uber to get these 600,000 people their chronic medication. But of course, that was great at the time, but it's certainly not sustainable or long-term. And so in that context, and in a way it speaks to some of the comments you made in December last year, where you spoke about the levels of stigma associated with health facilities, certainly at the peak of the pandemic, and how that has in effect shattered livelihoods, denied people access to essential medicines, etc. So in the first instance, how do we protect the investments that we've all worked on for many, many years in HIV, TB, malaria? And then secondly, have you seen any practical examples of how we can urgently start rebuilding faith in clinics, in the safety of clinics, in the importance of going to the clinic earlier rather than later for sickness, etc. So if you could share some perspectives on those two.
Yeah, so really great questions. To the first one, in terms of safeguarding the investments or the gains so far, I think for me, the best way to do that, and I think we've seen that with the HIV response, is to really invest in communities. which goes back to the point that no global health response will be won or successful without communities. And why I say that is because nobody has a better interest of the people than communities. So that's one. And number two is because communities can access anyone, anytime, can navigate within the response, can navigate within communities and neighborhoods and villages, etc., etc. So I think it's important to build an infrastructure that puts, first of all, community system strengthening at the center of it, and not as an afterthought, but puts community systems at the center of it, and then equip the community, you could say workers or community leaders or the community response with the tools and the resources that it actually needs. What we know, for example, if you take TB with the directly observed therapy or the door-to-door kind of visits, the people who actually sustain that response are the community leaders who check on the patients, who follow up, etc., etc. And so I think that's a model that has worked in TB, in HIV, and it's a model that should be scaled. Right now, a lot of it is done with no resources. So I think the notion that community can do this for free is something that we should challenge again. I think there's need for proper remuneration for the community systems piece, for community leaders who actually do that work. So there's something there to think about. How do you actually structure community responses, community leadership, community health workers kind of component within the whole response, because that's one way of ensuring that you safeguard the gains. And the next thing was what, Tian? The next question.
How do we build confidence? This is assuming that there was confidence before the pandemic in our public health systems, which are now essentially covered in many degrees with this heightened sense of stigma. People are not collecting their chronic medications. People are no longer adhering. There's a fear associated with clinics. And this is something I've heard certainly across the region. Are there innovative ways or strategies or suggestions that you can share with us today in terms of how do we start undoing that PR damage really that COVID has done to public health facilities?
Yeah, so literacy. First of all, the trust was gone way before COVID came about. A lot of people do not trust public systems. A lot of even colleagues and people we know, people we work with, cannot actually go to public health facilities because the trust with those is zero. So I think we need to think about how the public perception of the public health system, a public perception of facilities, public perception of their own government. So that's one. And number two, how do we understand access or behave, our health-seeking behavior, and what are the different determinants that really help us to determine or to decide whether we want to go access care or not. So when I talk about literacy, I'm reminded about the HIV movement again. I think we still have so many things to borrow from there, because literacy helps in terms of educating the public, educating the masses on the need to for these services, on the need to actually seek health services at public health facilities or whichever facility, but the need to actually go out and seek for care. I think with literacy, we can build trust. We can build a public perception that is embracive of the facilities, that is embracive of healthcare provision facilities and centers, that actually gets communities and basically anybody who is seeking care to trust and to show up when they actually need to show up. So I think it's literacy, and there's a lot to learn, from the HIV response, whether it's literacy about the different treatments, the different interventions. But within this case, we have a huge role of making health a public good, because right now it hasn't been, and that will help to shift the way people perceive health-seeking practices.
Absolutely, thanks for that. So we're 10 minutes to the top of the hour. Just to say, Peter, we see you speaking about, in terms of solidarity, can we take advantage of the Kampala initiatives, which talk to going beyond aid in relation to donor, profit, and people? Peter also speaking about corruption. Naomi mentioning the importance of domestic mobilization underpinned by accountability. A shout out again from Peter. Rosemary, you are talking to our spirit. Carol, it's important to anchor the response in the community led by and for the communities themselves. But I think as we reach the end of this discussion, Rosemary, could you share, it's nearly 1 year since the advent of the pandemic, depending on the work which any of us do, it feels like 50. But what is your one biggest concern today in terms of our response to COVID-19? And could you share with us the one moment in the last year in the context of COVID that really reaffirmed your faith in the work of civil society and made you proud to be the leader that you are in the space? So those two reflections, if you may.
Thank you. So one, with COVID-19, one of the things that stands out for me that actually needs attention or concerns me is around the lack of transparency and the nationalism that we are seeing. So in terms of lack of transparency, a specific case to cite in an area of concern is on the Act's Access to COVID-19 Accelerator, the facility that we talked about. And I see Peter Owiti here. He's a member of the Facilitation Council there. So very interesting to talk about a facility where actually he represents civil society within there. But what we are hearing from colleagues who sit there is the lack of transparency. And that limits civil society and communities' engagement and the way they can support ACT-A in its mandate of ensuring that COVID-19 tools are developed and distributed in an equitable manner. That lack of transparency means what? For example, civil society are not aware of how some of the decisions are being made. They are not aware of some of the entry points, et cetera, et cetera. So that's one. Number two, the lack of involvement of low and middle income countries. So what we are hearing also is that our countries, which really also are parts and stakeholders within the ACT-A, are not, the ACT-A remains vague for them, not knowing what the entry points are, not knowing what they're supposed to do with it, and no intentional outreach. We did see that yesterday, the first shipment from COVAX for vaccines to Africa arrived in Accra. And so very interested to know the dynamics around that and when we get the next shipment from COVAX to Africa. But still for me, the inequitability, the way we still don't have equitable access is very striking for me. The goal of COVAX is to distribute 2 billion doses by the end of 2021. We have all seen where the doses are going to be going, and we have seen the graph. And so it's very worrying in terms of equity. And I think that's an area to think about. One moment that I've been really super proud of civil society and communities and really confirms to me that I'm in the right sector and I'm here to stay. It's just how when COVID-19 came, last year was a very difficult year for the whole world, but it was a difficult year for civil society and communities, and we didn't know exactly how to respond. What we could see was that people were actually dying of TB, dying of malaria. People were not accessing health services. There was a huge challenge. Our families and friends were getting infected with COVID-19. We lost friends and families. So the element of resilience among civil society and communities is what wowed me. Like we kept going. We did Zoom after Zoom, Zoom after Zoom. It was so tiring, so exhausting. And there are times when you would sit behind the Zoom and say, hey, am I still saving lives? Behind the Zoom after Zoom after Zoom. But, you kept telling yourself, you had to show up. You had to wake up. You had to show up. You had to be in those meetings to really push for why communities need to be engaged in the trials, in the ACT-A. You needed to be in those meetings to really say why it's important for an equitable access to vaccines. So just showing up day after day made me really proud of civil society, of communities, and now the accountability that I'm seeing right, left, center around the vaccines, diagnostics, around the whole thing is amazing. So it has been a moment of pride, even though it has been a very difficult, but it has been so for everyone. So that's my reflection, Tian.
Thanks so much, Rosemary. Colleagues, Rosemary Mburu is the Executive Director of WACI Health. She's also a founding member of the Vaccine Advocacy Resource Group. Rosemary, thank you again for spending some of your Thursday morning with us. Colleagues, we look forward to welcoming you back next week, Thursday at the same time. Rosemary, have a wonderful Thursday. Take care, and we shall remain in touch and in solidarity. And congratulations again on all the work and the progress that has been made at the helm of WACI Health. Thank you.
Thank you for having me. Thank you.